Good evening, everyone. Ali Sahib Hussain from Kuwait. It's a pleasure to be here. Thanks for the invitation. Today I'll be presenting when both the valve and pipes fail. So this is an 83-year-old gentleman who's quite functional at baseline with no major comorbidities, presenting with high risk and STEMI. He was transferred from another center to our center for surgical evaluation and intervention, basically completed his workup, including a cath and angiogram from another center with no surgical backup. So here you can see the echocardiogram on the parasternal long axis view. You see the LV systolic function appears to be normal. The aortic valve looks heavily calcified and restricted in motion in both long axis and short axis view. When you look at the measurement, the aortic valve area is 0.8, and the mean gradient across the valve is 44 millimeter per mercury. This is in keeping with severe symptomatic aortic stenosis. So this is the patient angiogram looking at the RCA. You can see that the RCA looks heavily calcified with a tight lesion at the proximal portion, as well as another lesion in the RPDA. Looking at the left system, there is a significant distal left main stenosis of 60 to 70%, as well as heavily calcified circ and LAD, very tight prox to mid LAD. So the patient was seen by our surgical group, and patient was accepted for SAVR plus CABG. However, while awaiting for surgery, the patient developed refractory chest pain, dynamic ECG changes, and a very high troponin elevation at 147,000. A repeat echocardiogram in CCU showed that the patient now has a decline in their ejection fraction to 30%, was in cardiogenic shock requiring levo-fed. So upon re-evaluation of this patient, the surgeon felt that this patient is going to be a very high risk for open heart surgery given recent MI, drop in EF, and hemodynamic instability with a STS risk score of 40% for major morbidity or mortality at 30 days. So the patient was referred back to us for consideration of structural plus coronary intervention. So a couple of options here. You can basically do nothing, which is always an option. But if you decide to intervene, you can do the TAVI first, followed by a multi-vessel PCI. Or you can start with multi-vessel PCI followed by TAVI. And there's always this question of whether you're going to need to use a mechanical circulatory support. So just a brief review of the literature. Managing patients with severe aortic stenosis and concomitant CAD is very complex. There's really no randomized data to suggest what strategy we should use. But this is the activation trial, which was a randomized multi-center, small sample size patients presenting with severe aortic stenosis, basically randomized to either PCI or no PCI prior to TAVI. And you can see that there's really no benefit of PCI prior to TAVI in patients with severe aortic stenosis, but you may have an increased risk for bleeding. However, this is a small sample size and a trial that failed to meet non-inferiority margin. So the Notion 3 trial is a better designed trial, multi-center, larger study, 455 patients, and very important to know the population here. They had very severe CAD with a definition of 90% stenosis, or they had to have an FFR positive for them to be enrolled in this trial. In this trial, patients who had PCI actually did better and had a reduction in risk of myocardial infarction, as well as reduction in urgent revascularization. So the ongoing complete TAVR trial led by our friends in Vancouver is still ongoing, enrolling patients after balloon expandable valves. Patients will be randomized to either PCI complete revasc or medical therapy, and I believe this will be informing in terms of practice and may give us definitive answers. If you decide to intervene for those patients, you have two options. Either you go with open heart, CABG SAVR versus TAVI PCI. So there's really no randomized trial comparing both strategies, but this is a large multi-center trial from Spain that included above 1,000 patients. Those patients were intermediate surgical risk, and the primary outcome was all-cause death or stroke at 30 days. You can see the green line is percutaneous intervention, TAVI PCI. Red line is surgery. And patients who had TAVI PCI actually did better. So there was a reduction in mortality or stroke in patients who had a percutaneous intervention. So what we usually do for those patients, we like to fix the valve first. And we think fixing the valve first will give you this hemodynamic support to fix the arteries, especially if the arteries are very complex and need calcium modification. The last thing you want to do is fix the arteries, and then the patient goes hypotensive, arrest, and then you're doing CPR in a patient with severe aortic stenosis. To me, this is game over. So usually we like to fix the valve first. However, for this patient, given the recent ACS presentation, query ischemic event, very high troponin, and the need for mechanical circulatory support, we thought we'll use an Ampella-guided or assisted PCI, because we don't really like to push an Ampella inside a fresh transcatheter valve. There is always a risk of damaging this new valve or a valve embolization. But then the question becomes, can we put an Ampella in a patient with severe aortic stenosis? And the answer is yes. So you can either balloon the valve or just do as what we did. Basically cross the valve, push the Ampella against a stenotic valve, and I have to be honest, it did require a lot of push. So you can see on the proximal shaft of the Ampella, there is a kink now. And this is just basically because of pushing hard across a stenotic valve. Despite that kink, the Ampella was fully functional and maintaining a good cardiac output at 2.7 liters per minute. We did not really want to balloon the valve, because when you balloon the valve, you have to rapidly pace those patients. And when patients have significant CAD, already in shock, this rapid pacing can cause more ischemia and cardiac arrest. Next, we moved to fix the RCA with orbital atherectomy, and then stented the proximal as well as the RPDA with good results. We pre-dilated the LAD, orbital atherectomy of the LAD, proper lesion preparation, and then stenting of the prox, as well as ostial LAD back to the left main, did a pot, final result looked very good. So we thought the case is done, but the patient then became really hypotensive with a blood pressure of 70 systolic. The patient, we used the right femoral artery for the main axis where the Ampella was going. The left femoral artery was a 7 French sheath that was connected to anesthesia for hemodynamic monitoring. And we noticed that that sheath was pulled out accidentally. So there was a big hematoma. We could not really put manual pressure. I thought what I'm going to do is I'm going to put a larger sheath above the first puncture site. So I put in a 9 French sheath above the puncture site, and then the patient was fully heparinized because he was having an Ampella in situ as well as recent PCI. So protamine was not really seemed to be an attractive idea here. So took a picture with the 9 French sheath, which is above the puncture site, and you see extravasation and failed to seal. This is probably from the first 7 French sheath that did not really close. Then what we did is we have a contralateral axis, which is the Ampella site, wired this, ballooned, did an injection with a 9 French sheath, and you still see some extravasation despite balloon tamponading and having a sheath beside this balloon. So we decided we're going to go stenting this with a self-expanding covered stent, followed by ballooning of that stent, and the final result looked very good. So we managed to land just above the bifurcation without really compromising any of those branches. Lastly, we then moved to the TAVI. So you see a balloon valvuloplasty of the valve with a non-compliant balloon, a Safari extra small wire across the valve. We went with an accurate Neo2 large size, which is a self-expanding supraannular valve. This valve is now recalled and not available in the market. At the time, it was available. Finally, you see the deployment of the valve. We knew that this valve, if left underexpanded, had significant issues, so we had a really low threshold to post-dilate those valves with non-compliant balloons, and the final result looked very good. So echocardiogram at 30 days after the TAVI showed a well-seated transcatheter valve. The mean gradient was only 6, and there was really no leak. This patient, we were able to follow up on him 6 months after the procedure at the heart valve clinic at Jabir Hospital, remained very well, very functional, and really appreciate the overall outcome. Thank you for listening.